Hi, my name is Yasmeen, and I'm a fourth-year medical student. Today we'll be talking about glomerular filtration and the renal plasma flow. It's part of renal physiology, around like the third and fourth lectures of renal physiology. Before I start, I'll go over the contents of today's lecture. First, we'll have a quick introduction about the kidney structure and function to know what we exactly are talking about. And then we will talk about the filtration barrier and the factors affecting this barrier. Then we will go about, for the glomerular filtration, which is going to be the bulk of our lecture. We will know the determinants of the GFR and how it's controlled. Last part is going to be the tubuloglomerular feedback. And lastly, we will have some questions to go over. First, let's go over the kidney, what we know already. So this is the gross structure of the kidney. This is the gross anatomy. Each kidney has many pyramids, which we can see grossly, but if we zoom in more here, we can see that we have the functional structure of the kidney, which is the nephron. The nephron consists of the renal corpuscle and the tubules. Here we can see renal corpuscle, and it's the main structure we're going to talk about today in our lecture, and then there's later the tubules coming out of it. So the main function of the kidney we know is to produce urine, and by producing that urine, we will have a balance of the electrolyte and fluid levels of the body. We will be excreting unwanted substances and the waste product. So as I mentioned, the urine production is the main way of doing all of these important functions. So today's lecture about filtration. Filtration is the first part of the urine production and the first part of all of these steps and all of these benefits of the urine and the kidney function. So there's the corpuscle, zoomed in. That's the afferent arteriole, and then we have the glomerular capillaries, and then there's the efferent arteriole. So this part is where the filtration is happening, and it depends on two things: the renal blood flow and the glomerular capillary properties, which what we call the filtration barrier. We will go over it in more specific details. One thing also about glomerular capillaries that you have to know is that they have high selective permeability. And let me just turn on the pointer. And when we go over the filtration barrier, you will understand what that means and how is it achievable to have selective permeability, although it has a very high filtration rate. So let's talk about the filtration barrier. Like I mentioned, the filtration happens in the corpuscle and specifically in the glomerular capillaries. So for the filtration to happen, the blood has to be filtered from the glomerular capillaries and go out as filtrate fluid to the Bowman's capsule. So the filtration barrier is basically the glomerular capillary wall. And this is a zoomed in picture of the glomerular capillary wall. You can see there is here 3 layers for this capillary, unlike the usual 2 layers for most of the capillaries in the body. So these 3 layers are endothelium and the basement membrane, and we have also the podocyte layer. Although this filtration barrier has 3 layers, it actually has much higher permeability than most of the capillaries in the body, and it filters so much higher than the usual capillaries. This is due to multiple factors. One of them is that the endothelium, the most interior part of this filtration barrier, is actually fenestrated. So we have holes in it that allows for high filtration. And of course, other factors we will discuss today in the filtration barrier. Also, you should know that the barrier is negatively charged, and this is very important in determining which molecules are going to be filtered through the glomerular capillaries. The charge plays a very important role. Filtration barrier, this is again from a more zoomed in view. So this is the endothelium, this is the basement membrane, and this is the podocyte. So I mentioned it's negative charged. How is this negative charge achieved? So for the endothelium, there's glycoproteins that are called glycocalyx, and the same thing for the podocyte. They both have the same glycoprotein. However, for the basement membrane, we have something called sialic acid, we have heparin, and we have sialoprotein. So all of the layers of the filtration barrier are all negatively charged. And as we can see here, here are the endothelium fenestrae or the endothelium pores. So here, the endothelium pores are around 70 to 100 nanometers, let's say around 80. And the podocyte, the outer layer, have pores of 20 to 30 nanometers. So again, all of them are negatively charged. They have pores that allow for filtration of the different molecules. Now, I mentioned multiple times that it's negatively charged. Why does that matter? First, let's talk about the two most important filtration factors in filtering any substance, any solute, any molecule. One is the molecular size, and the second is the electrical charge. So molecular size, it kind of makes sense. The bigger the molecule, the less the filterability, the less is easily filtered. So here we have this table. So water is kind of like the standard molecule. It's easily filterable, and it's what we call freely filterable. And it has a filterability of 1, and it's the standard that we compare to. And as you can see here in this table, as we go higher in the molecular weight, some molecules like myoglobin have less filterability, and albumin is a protein which is approaching 0 filterability. So what does this value mean? So when we say 0.75 filterability, we said the water is the standard. So this is filtered as easily as like 70% of water. This is how we look at it. And albumin is not filtered at all. Normally, we shouldn't have albumin or any protein in the urine. They are not filtered in the urine. And this is due to 1, the molecular weight is very high. And 2, like we mentioned, the other filtration factor is the electrical charge. So how does the electrical charge play a role in filterability? Look at this graph here. So if the filtration barrier is negatively charged, we learned from chemistry that similar charges repel from each other and different charges kind of attract each other. So knowing that, it would make sense that the positive molecules have higher filtration than the negative ones. Now, if we look here, this is the relative filterability, and this is the radius. Here are the charge. So for the same radius, let's look at this size, for example, 30. For the same size of molecule, something that's positively charged is filtered higher than a neutral dextran. In this case, we are comparing dextrans, which are polysaccharides. So something that's positively charged is filtered higher than neutral ones and much higher than negative ones. And again, we are comparing the same size. Again, the bigger the size, the less easy the filterability. So naturally, all of positive or negative or neutral charges, the bigger the size of the molecule, the less filterability the molecule has. And it's the less easy to filter. But this graph is specifically concerned about the electrical charge. Again, positive is much more easier to be filtered through the filtration barrier. That's because of its negative charge. However, this electrical charge has very small or no effect on the filterability of small molecules like electrolytes. So large molecules, they will be affected more by this electrical charge. And if we go back to this graph, again, it says here dextran, which is a polysaccharide. Electrolytes are much, much smaller than a polysaccharide, and they are less affected by their charge. Basically, they are filtered anyways, whether they are positive or negative charge. And these are some substances that you should know that they are not freely filtered. Most important one is proteins. This is mainly due to 2 reasons. 1, it's big in size. 2, it's positively charged. So again, let's go back here. Something that's in the bigger side with a negative charge is going to be almost like 0 filterability. And this explains the albumin having a 0.005 filterability. So protein in the urine shouldn't be there. It's just not normal. And unless there is a defect in the filtration barrier, a normal person shouldn't have protein in the urine. And we have also lipid-soluble bilirubin and lipid-soluble hormones. The reason these are not filtered easily, for the same reason, because they are most likely, most of the time, bound to proteins. So if the proteins aren't filtered, any molecule binding to them is not going to be filtered as well. So what is the clinical relevance of these filtration factor? You should know that losing this negative charge is going to be a loss of like a protective factor against losing protein. So normally we shouldn't lose protein because of the natural negative charge in this filtration barrier. If for any reason a patient loses their filtration barrier negative charge, we will have protein leakage into the urine, and it's what we call proteinuria, the presence of protein in the urine. Something that was mentioned in the slides, it's called nephrin mutation. This nephrin mutation will cause a defect in the filtration barrier, and we will have what we call congenital nephrotic syndrome. Nephrotic syndrome is something that's not like taught to first year, but it's basically the loss of protein in the urine. So knowing what we know now about the filtration barrier, these characteristics for the glomerular filtrate should make sense. One, it's protein-free. Normally, again, this is very important information. You should know that the glomerular filtrate is a protein-free filtrate. No cellular elements, so no red blood cells at all. No white blood cells normally. And it's isoosmotic to plasma. And most of the small molecules have similar concentration. Some exceptions are free fatty acids and calcium. And this is because they are mostly bound to proteins. So we mentioned anything bound to proteins is not going to be filtered because proteins aren't filtered in the first place. So anything binding to them, like free fatty acids and calcium, isn't filtered. And for the red blood cells, one of the main reasons they are not filtered, one of the reasons we normally as humans, we don't have red blood cells or blood basically in the urine is because they are huge compared to the pore size and for the endothelium fenestri of the filtration barrier. So a red blood cells is around 4,000 nanometers when the pores are 70 to 100. So it's huge compared to the filtration like barrier pores. Now we come to glomerular filtration rate. It's the bulk of today's lecture. It's like most of like the lecture, like heavy content. So what is glomerular filtration rate? It's basically a value that is milliliters per minute of how much a glomeruli of the kidney is filtering per minute or per day. So normally glomeruli filter 125 mils per minute or a total of 180 liters per day. This is kind of an average value for most of the humans. For females, it's a bit less than males, and there is some variation. So for females, it's around 110 less or more, and for male is 125 less or more. And of course, in a newborn, it's much less. It's 20 mils per minute. Their kidneys, their body volume is completely different. And for an aged person, so someone from the age of 45 to 50, this is when they start having declining GFR. This is normal physiology. So by the age they are 80, they have 30 to 40% lower GFR. They lose around 1 mil of 1 mil per minute of their GFR per year. So if we are filtering 180 liters per day, how is that possible? Like we don't even have this much volume of like blood or liquids in our body. So this happens because 99% of this GFR is actually reabsorbed in the tubules by the peritubular capillaries and in the tubular system in general. This GFR is relevant to know in calculation of two important parameters. One is filtration fraction and the other is filtered rate. So filtration fraction is basically glomerular filtration rate over the renal plasma flow. It's basically telling you how much of the blood going into the kidney is being filtered. So let's say the kidney is taking, both kidneys are taking 625 mils per minute, and there is a filtration of 125. So 125 over the RPF is going to be around 0.2 or 20%. So 20% of the plasma flowing into the kidney is being filtered. This is the filtration fraction. And you will see how relevant it is in other parts of this lecture and how different changes in the GFR will have different effects on the filtration fraction. Filtered rate is basically calculating how much of a substance is being filtered. This is assuming that the substance is freely filtered, and not all substances are freely filtered. So, but if it is freely filtered, basically you multiply the GFR by the plasma concentration of whatever substance you are using. So again, this is the same graph showing you that GFR is 125, but most of it is reabsorbed. And this 125 is approximately like 20% of the renal plasma flow. So what are the determinants of GFR? Or in another way, what makes GFR 125? What makes it less or more than like from one person to another? What makes a GFR change in one person in different physiological states? So we have two main like variables in the GFR, which are the net filtration pressure and the capillary filtration coefficient. And this is exactly the equation. So GFR equals the capillary filtration coefficient, which is Kf, and net filtration pressure. Now, this doesn't make any sense now because we don't know what is a capillary filtration coefficient, and we don't know what's net filtration pressure. But we will go over it in details. So we will talk about the filtration coefficient, but for the net filtration pressure, it's basically this equation, which is the pressure, the hydrostatic pressure of the glomerular capillary minus the hydrostatic pressure of the Bowman's capsule minus the oncotic pressure of glomerular capillaries. Now, this sounds complicated, but if you understand these variables and how they affect GFR, it's going to be so easy to memorize. So in like short, there are four determinants of GFR, these four. Again, the filtration coefficient and the net filtration pressure. We have three values that affect the net filtration pressure. Glomerular capillary hydrostatic pressure, Bowman's capsule hydrostatic pressure, and glomerular capillary oncotic pressure. There is here one missing thing, which is the Bowman's capsule oncotic pressure. We didn't put it here because it's basically zero. We just mentioned that protein is not filtered. So if protein is not filtered, Bowman's capsule is not going to get any protein. And this will lead to our oncotic pressure of Bowman's capsule to be zero. But these, however, are relevant and they are changeable by different measures. So let's talk about filtration coefficient first. It's like a property for the glomerular capillaries that allows it for much higher filtration rate than other capillaries. What it measures is basically hydraulic conductivity and filtration surface area. So it tells you how much this capillary is allowed to filter and how much does it allow of water to leak. And it depends, again, it's hydraulic conductivity, so it depends on water permeability, how much these glomerular capillaries are allowing the water to get out of them. And it depends also on the total surface area. So if you have higher total surface area, this is going to allow, again, for more filtration. It makes sense. If we have more surface area for the blood to go into and to be filtered, then this will lead to more filtration. And water permeability, again, it's a property of the glomerular capillaries. So if you look here, the filtration coefficient of glomerular capillaries is 12.5. While in other tissue, it's 0.01. So it's much, much, much higher in the glomerular capillaries. And this is one of the properties of a capillary that allows it for having a much higher filtration rate than the normal capillary in other tissues in the body. About the other part here is net filtration pressure. So what is net filtration pressure? We're talking about filtration, a pressure that's pushing the water, the blood, basically to be filtered. So from this equation, you know, it's something that if it's higher, it increases the GFR, and if it's slower, it decreases GFR. Again, filtration coefficient, if it's higher, again, increase in GFR, and if it's lower, it's decreasing the GFR. It has a direct positive correlation to the GFR. How can a change in the filtration coefficient happen? So mesangial cells that are around the glomerular capillaries, if they are relaxed, they allow for higher surface area. And we just mentioned the glomerular capillary's filtration coefficient is depending on two things. One is water permeability, and the other is the surface area. And allowing for much more surface area here will allow for a higher filtration coefficient. And in some diseases, the filtration coefficient can be decreased by a thickened basement membrane. So basement membrane is the middle layer in the filtration barrier. Logically, if it's thickened, it's not going to allow for filtration, or it's not going to allow for water to leak out of the capillaries easier. So it will decrease the filtration coefficient. And some diseases, this is mentioned, is chronic hypertension or diabetes. These are diseases that affect the basement membrane of the capillaries and decrease the filtration coefficient. So again, a direct relationship. Increase causes increase in GFR, decrease causes decrease in GFR. Now let's talk about net filtration pressure, how we can calculate it, and what makes the variables affect the filtration. So we studied in CVB the Stirling forces, the hydrostatic pressure, the oncotic pressure, or the colloid osmotic pressure, and how they affect capillaries and the water moving around different surfaces. So hydrostatic pressure, as we can recall, it's the pressure that the blood or the liquid in the vessels is applying on the capillary walls. So the glomerular hydrostatic pressure, if it's higher, it's going to push the blood more, it's going to push the fluid more to be filtered. And the colloid osmotic pressure is the opposite. So if it's higher, it want to take a fluid, like it wants to have more water to like equalize the protein concentration. And here it's the Bowman capsule, the other side. So the other side, the higher the hydrostatic pressure here is going to push the fluid to not be moved here. So what are, out of these three, one variable, one pressure is pushing for filtration, and these two are against filtration. And this explains why the net filtration pressure is the glomerular hydrostatic pressure minus these two, because this is the pressure that's applying for more filtration. This is the pressure that's wanting to filtrate the blood, and these two are on the other side. So to calculate net filtration pressure, we have the glomerular hydrostatic pressure, 60, and we subtract these two from it because these two are opposing the glomerular hydrostatic pressure effect. And this is how we get the net filtration pressure. So again, 60 minus 32 minus 18 is going to give us around 10 for the net filtration pressure. This is, again, these are average values for majority of human beings, applicable to most. So if we put these values, the filtration coefficient, which is 12.5, multiplied by 10, the filtration pressure we just get, we're going to have 125 mils per minute. Again, the GFR we just mentioned earlier in the slides. So these are the determinants of GFR and how they affect the GFR. Filtration coefficient, if it's increased, it increases the GFR. The glomerular capillary hydrostatic pressure, if it increases, again, increases the GFR. But the Bowman's capsule hydrostatic pressure decreases the GFR. And the glomerular capillary oncotic pressure decreases the GFR. Those both affect the GFR negatively, and those two affect it positively. They increase the GFR. So let's discuss each and every one of these changes of like Stirling forces and how can they be changed in their different physiological variables. So for the glomerular capillary hydrostatic pressure, it's mainly under three physiological variables: the arterial pressure, the efferent arterial resistance, and the afferent arterial resistance. So first one let's talk about is arterial pressure. So the glomerular capillaries, we know they are branching from the afferent arteriole. And the afferent arteriole is a branch of a branch of a branch of what? Of the renal artery. So it's coming mainly from the systematic arteries. And logically, if you think about it, the arterial pressure is going to affect it. The higher the arterial pressure, the higher is going to be the pressure in these arterioles and the glomerular capillaries, and then will, of course, increase the hydrostatic pressure of the glomerular capillaries. So this is, again, the same picture of the corpuscle. So afferent arteriole, it's coming from the system. So if we have higher pressure coming in here from the arterial pressure, it's going to have an effect on the glomerular capillaries by increasing these glomerular capillaries hydrostatic pressure. And this increase in glomerular hydrostatic pressure is going to increase filtration. However, in reality, it doesn't have a very strong effect. The arterial pressure doesn't actually have a very strong effect on the GFR. This is due to the autoregulatory mechanisms by the kidney that keeps a constant GFR. So this, out of these three, this one has the least effect on the glomerular capillary hydrostatic pressure. And the next one is the efferent arteriole resistant. طيب, let's look at this picture here. This is again the glomerular capillaries in the middle. This is the afferent, and this is the efferent. So if the efferent one here is not allowing the blood to leave easily, in other words, it has higher resistance, how would that affect the glomerular capillary hydrostatic pressure? That will actually increase it, because the glomerular capillaries, the blood is coming in normally, but the glomerular capillaries are not allowed to take the blood out as easily. So this will increase the hydrostatic pressure of the glomerular capillaries. And if we increase the hydrostatic pressure of the glomerular capillaries, we know by now that the higher the hydrostatic pressure in the glomerular capillaries, the higher the GFR. So this is one of the way that a kidney can increase the GFR, by increasing the hydrostatic pressure, by increasing the efferent arteriole resistance. However, this effect is to a certain point. So it increases resistance of the glomerular capillaries to a certain point before the renal blood flow becomes so reduced that actually the glomerular filtration rate decrease. So here is the normal. Normally, this is the GFR, and this is the renal blood flow. With more resistance in the efferent arteriole, more constriction here, the GFR is increasing, although the renal blood flow is slightly decreasing. But after a certain point, the renal blood flow decrease cannot keep up with the normal GFR. So the GFR actually start decreasing. So this effect has like a certain point where it can be reached, and then it start having a negative effect on the glomerular filtration rate. This is because like the renal blood flow will be so compromised that like it cannot achieve like a normal plasma concentration here, and thus will of course have like a negative effect on the glomerular filtration rate. Okay, so if the GFR is higher and the renal plasma flow is slightly lower, from the filtration fraction equation, this mathematically will lead to filtration fraction increase. Because let's say even if the renal plasma flow is still the same, an increase in the GFR can increase the filtration fraction. And in this case, the filtration fraction increases even more because we have a decrease in the renal plasma flow and an increase in the GFR. Again, filtration fraction represents the value of how much of the blood you're giving the kidney is being filtered. In this case, it's high because you're giving the kidney even a bit less blood, but it's filtering more. So the filtration fraction is here higher. The causes for efferent arteriole resistance is high or strong sympathetic stimulation and moderate, or let's say physiological level of angiotensin II. So if in causes of stress, higher sympathetic stimulation, this will happen to increase the GFR with lower renal blood flow. Last variable we are going to look today for the glomerular capillary hydrostatic pressure is the afferent arteriole resistant. What is PG? Sorry, I did not see that earlier. So PG is the pressure of the glomerular capillary. This is like a shortcut for it. Pressure, the hydrostatic pressure. The oncotic pressure has like a pi sign for it. This is the hydrostatic pressure of the glomerular capillaries. Okay, now let's look at what happens if the afferent arterioles are restricted or constricted and have higher resistance. So this case is a bit different. Here, the afferent arteriole is what's bringing the blood into the glomerular capillaries. So if they are constricted, what's going to happen is less blood is going to come into the glomerular capillaries. And this means less hydrostatic pressure and even less GFR. And this one is more direct than the efferent arteriole resistant. Because if you look here, it's just like almost a linear relationship between them. You're gonna diminish the renal blood flow and you're gonna diminish the glomerular filtration rate. Again, because this is the afferent arteriole, it's what's bringing the blood into the glomeruli. The efferent is not as affected, so blood is leaving easily, but it's not entering as easily. You don't have as much blood going into the glomeruli as it normally would. So that would cause a decrease in the capillary hydrostatic pressure and a decrease in the GFR. And a decrease in both is gonna keep around the same filtration factor. طيب. Again, peritubular capillaries. Remember, they are structures that are coming from the efferent arteriole. So efferent arteriole, after it leaves the corpuscle, there is branching of the efferent arteriole, and we have the peritubular capillaries. So either constriction of afferent or efferent will cause a decrease in the peritubular capillaries. This is because either ways you have decreased blood flow. Either ways, the blood leaving the corpuscle is gonna be slightly less. So if the constriction is here, we have less blood here and less blood here. And of course, the peritubular capillaries are gonna even have less because they are branches of the efferent. And same case if the constriction is here. If the vasoconstrictor is applied here, yes, we will have higher GFR, but again, the blood leaving the efferent arteriole is less. So peritubular capillaries are gonna have less hydrostatic pressure. And peritubular capillaries, that will lead to more reabsorption, and that's something we will discuss by the end of this lecture, the peritubular capillaries and how they're affected by the different resistance. So the causes of this arterial resistance is mainly two. Again, the same angiotensin and sympathetic stimulation, but here it's more under the effect of angiotensin. So it's when we have very high angiotensin. And the efferent arterial resistance, it's when we have a very strong sympathetic stimulation. So this one is predominated by angiotensin, while the efferent is predominated by sympathetic stimulation. Okay, now we are done with the hydrostatic pressure of the glomerular capillaries and what affects them and the variables that affect them. We will look at a different force that affect the GFR, which is the glomerular capillary oncotic pressure. We mentioned that it has a negative effect on the net filtration pressure because it opposes filtration. It's a negative effect because if the higher the oncotic pressure, the lower the filtration. So if increased, it reduces GFR, but without affecting the renal plasma flow. There is no reason for a change on the oncotic pressure in the glomerular capillary to change the renal blood flow. The reasons we discussed earlier that change the renal plasma flow is because it's happening in the arterioles and it has to do with the resistance of the renal blood flow coming in. But the oncotic pressure does not change the RPF. So if something is reducing GFR, but keeping the RPF the same, how would that affect the filtration fraction, which is again the GFR over the renal plasma filtration? That would reduce it because GFR is again reduced, renal plasma flow is the same. But if we have decreased oncotic pressure for some reason, we increase the GFR. And again, there is no reason that oncotic pressure affect the renal plasma flow. So we have increased filtration fraction. So let's look here to understand what we are talking about. Let's assume that this is a glomerular capillary and it's filtering here to Bowman's capsule. We mentioned many times by now that proteins are not filtered. So here, like this is the beginning, filtered some fluid, but the protein stayed. Here we even filtered more fluid, protein stayed. Again, we are filtering fluid, but the protein stayed. By the end of the capillary, you will find that the protein concentration is actually increasing because we are losing fluid into the filtrate, we are losing fluid into the Bowman's capsule, but the proteins are staying, they are not filtered. So if we compare the beginning of the glomerular capillary with the end of the glomerular capillary, we will find that oncotic pressure here is higher, and this is normal, this is physiological. So let's look here for the distance along a glomerular capillary. This is from the afferent end, and this is the efferent end. Let's look at this one first, the normal one. So from the afferent end, it's around 28. We are filtering, but the protein is staying, filtering, but the protein is staying. So the oncotic pressure is normally increasing. And this is compared to different filtration fraction. So what are the reasons for increased oncotic pressure? One, normally plasma protein, if it's increased, again, the glomerular capillaries are getting their plasma from the system. For any reason, the plasma protein got increased, got higher, that will cause a higher oncotic pressure in the glomerular capillary. Second reason, which is in this graph shown, is if we have higher filtration fraction. So if we give the kidney the same amount of fluid, but it's filtering more. This is what the filtration factor is how much of the blood you are giving the kidney, it's getting filtered. So if it's filtering more, it's giving more fluid. But again, protein is staying anyways. Whether we are filtering more or less, protein is not filtered to begin with. Filtering more, you will see that even more concentration of protein is staying because we are losing more fluid for the same amount of protein. And this is represented here in this line. So again, we are filtering even more. We have higher filtration fraction. You will see here that the distance while we go, the oncotic pressure is increasing because we are filtering more fluid, but the proteins are staying. And if for any reason we have filtration factor that is less than the normal, we are not losing as much protein, so the oncotic pressure is not getting as high as normally it would by the end of the capillary. Now, as I said, the higher oncotic pressure in the end of the capillary is normal, it's physiological. And it's one of the things that stop the filtration at some point in the capillary. So we said that the oncotic pressure is opposing the filtration because it's trying to keep the fluid with the glomerular capillary. So if by the end of the capillary you have really higher, like very high oncotic pressure compared to the beginning, this will stop the filtration. This will reach to an equilibrium of pressures. So by the end of the glomerular capillary, we will see that the filtration has stopped for many reasons. One of them is, again, the higher oncotic pressure. So reasons for increased oncotic pressure, again, higher plasma protein. And reasons for decreased oncotic pressure is decreased plasma protein for any reason, whether is it malnutrition, it's nephrotic syndrome, any cause that cause lower plasma protein, we will have decreased oncotic pressure. Here again, one of the reasons for increased oncotic pressure is lower RBF. I just explained how higher filtration fraction will cause increased oncotic pressure because we are filtering more fluid for the same amount of protein staying in the capillaries. So if we have less renal plasma flow, that will actually increase the filtration fraction. So this is another way that filtration fraction is affecting the oncotic pressure. So this is basically just telling you how, like, in another way, filtration fraction increasing and causing the oncotic pressure to be higher and to reach equilibrium faster. As you can see here, there is a straight line. Okay, now we are done with the oncotic pressure of for the glomerular capillary. Sorry, now we'll talk about the Bowman's capsule hydrostatic pressure. So I just mentioned a few minutes ago that an increase of hydrostatic pressure in the Bowman's capsule will actually reduce net filtration. That's because Bowman's capsule, if it has high hydrostatic pressure, it's going to try to push the fluid not to come into the Bowman's capsule. This is how hydrostatic pressure works. It pushes the fluid to the other side. What other causes can have like an increased hydrostatic pressure in the Bowman's capsule? So Bowman's capsule is first place of like making the urine. So for any reason we have obstruction anywhere in the urinary system, this will cause the urine to accumulate and not move as easily and will increase the Bowman's capsule hydrostatic pressure. And if we look here, again, this is the same picture of a kidney. Any obstruction anywhere in the urinary system, whether it's here, anywhere that's obstructing the kidney enough to be obstructing like the nephrons, will cause the filtrate to accumulate and not pass as easily, and we will have higher Bowman capsule hydrostatic pressure. This has a negative effect on GFR, as we mentioned earlier, and it reduces GFR again by any obstruction. However, this effect is only on Bowman's capsule. It doesn't have anything to do with renal plasma filtration, renal plasma flow, sorry. So it's something that's happening later on after the renal blood flow is coming in and being filtered. So it doesn't have any effect. It doesn't increase it. It doesn't decrease it. It's totally has to do only with the GFR. So if we have GFR that's less for the same renal plasma flow, again, filtration fraction is GFR over renal plasma flow. It's how much of the blood is being filtered. So in this case, we will have less filtration fraction because the blood flow into the kidney is the same. It's not affected. There isn't any cause that's stopping the blood flow. But there is a cause the filtration. There is something that's stopping the filtration. So the filtration fraction, the amount of the blood that's being filtered is much less than the normal. So we have a reduced filtration fraction. These are all of the GFR determinants. A summary. These are the different changes. So efferent arteriole constriction, afferent arteriole constriction, glomerular oncotic pressure, Bowman's hydrostatic pressure. This is a similar table and the one that is in your slides, except I added here the causes for it to be more inclusive. So we talked earlier about the peritubular capillaries, but it was very brief. I didn't go into details because we will go into the details now. So let's review the structure again. This is an afferent arteriole coming in to the glomerular capillaries. We have filtration happening. Filtration happened. The rest of the blood leaves to the efferent arteriole. The efferent arteriole later on branches into the peritubular capillaries. So if for any reason a constriction happens here or here, either way the peritubular capillaries, because they come later on, they come after the efferent, a constriction here or here is going to cause less hydrostatic pressure into the peritubular capillaries. We are not allowing as much blood as normal to go in. So a constriction and afferent arteriole and efferent arteriole have different effects on the GFR and the renal blood flow, but it's the same effect on the peritubular capillaries because they come later. They are not in between like the glomerular capillaries. As we mentioned earlier, the filtration is very high, is around 125 milliliters per minute. And most of this filtration is reabsorbed. Most of this filtrate is reabsorbed. So this is because of the the peritubular capillaries reabsorption forces. And how this reabsorption is achieved. One, we have lower hydrostatic pressure in these capillaries. So if the hydrostatic pressure is lower, this will allow for more reabsorption. Hydrostatic pressure is, again, it's what's pressing on the capillary walls to push the fluid to the other side. So in the peritubular capillaries, it's actually low. So this will allow for more reabsorption. So one of these forces is lower hydrostatic pressure in the capillaries. Second one is plasma oncotic pressure. So this one in the peritubular capillaries have actually plasma oncotic pressure of higher value. This is one of the causes is the blood in the efferent arteriole. We just talked about how it's having higher oncotic pressure because we have higher protein concentration here. So we have, again, plasma oncotic pressure that is higher here because, again, the peritubular capillaries are branches of the efferent arteriole. They're affected by whatever is happening in all of these arterioles, afferent or efferent or glomerular capillaries. So we have plasma oncotic pressure that's high. And in this case, here it was kind of a negative effect on GFR, but in this case, because the peritubular capillaries are, their job is to reabsorb, it's helping it to reabsorb more, the high oncotic pressure. And it's absorbing from both the interstitium and the tubules. And again, there's a net filtration pressure here. It favors the reabsorption in this case more than the filtration here. Okay. And also in the peritubular capillaries, we have the same filtration coefficient we talked about. It has also, again, higher filtration coefficient. So in this case, a higher filtration coefficient is going to allow for increased reabsorption. And like I mentioned earlier, constriction of either the afferent or the efferent arteriole will cause a drop in the hydrostatic pressure in the peritubular capillaries, and we will have increased reabsorption. Again, whether it's the constriction is here or here, this will have same effect because the peritubular capillaries are just branches of the efferent arteriole. They come after all of this mess. So same effect of the arterial pressure. If we have higher arterial pressure, we have higher peritubular capillaries because, as we mentioned, anything that happens here, afferent arteriole, efferent arteriole, arterial pressure that's coming from the system into the afferent, all of it is going to have an effect on the peritubular capillaries. So for any reason, we have higher arterial pressure. We have also higher peritubular capillaries hydrostatic pressure. And in this case, we will have decreased reabsorption if we have high hydrostatic pressure in the peritubular capillaries. Again, peritubular capillaries have a higher oncotic pressure. Sorry. Okay. In this case, like I mentioned, anything that's going on in the plasma is going to affect the peritubular capillaries. So if we have higher plasma oncotic pressure, we will have a higher peritubular oncotic pressure. And here it should say increased reabsorption. I'm sorry, I think this is a mistake. I'll fix it later. And if we have higher filtration fraction, we just explained how higher filtration fraction will cause an oncotic pressure in the end result of the glomerular capillaries that's higher. So if we have a higher filtration fraction, the blood leaving the glomerular capillaries is going to be with higher oncotic pressure. We will have here again, it's a branch, so we'll have here a higher oncotic pressure, and this will allow for increased reabsorption, not decrease. This is a mistake here in the slide. Last part of today's lecture is tubuloglomerular feedback. So after this filtration comes in place in glomeruli, the filtrate is gonna go through the tubules. It's gonna be changed in different ways in the tubules. And in the tubules, they send a feedback to the glomeruli to change the GFR accordingly, how much we have of filtrate. If the kidney is filtering less, we'll send a signal to the kidney to filter more. And if the kidney is not, if it's filtering more than we need, we will send the signal to decrease the GFR. How is that achieved? First, let's look again on the structure of a nephron. This is a corpuscle, and these are the tubules. So if you can see here, the tubules are not straight structure that's coming out of the corpuscle like in a straight line. No, it's actually convoluted and it's coming down and up. So one part of the distal tube called the macula densa is in direct contact here in the afferent and efferent arteriole. It's in the distal tube, but because of this structure of the tubules, it's in direct contact. And these cells in the macula densa, they are sensitive to sodium chloride. And sodium chloride to these cells in macula densa, they represent how much of a filtrate we have. So if we have high sodium chloride, for the macula densa cells, This translates to, oh, we have a high filtrate. So slow down kidney with less filtration. And if we have a low sodium chloride, then we need to filter more because this is not normal. We should have higher sodium chloride. So how is this achieved? We will talk about the cellular level, about the macula densa and how they affect the arterioles. Again, they are in direct contact. So this is a macula densa cell. These are the cells of the arterioles. So this is smooth muscle cells on the afferent arterioles. And again, they are in direct contact. So step one here, the sodium chloride is taken up by the macula densa cell. Let's say here we have high sodium chloride. It's going to be taken up by the macula densa cells. And inside the macula densa, when we have high sodium chloride, we will have increased formation and release of ATP. So here we have ATP, and this is adenosine. So higher ATP and higher adenosine in case of higher sodium chloride. These will bind to the receptors on the afferent arteriole cells. So we have granular cells and we have smooth muscle cells. So they will bind out first on the smooth muscle cell on these two receptors. So the ATP will bind onto the P2X receptor, and the adenosine will bind to what we call A1 receptor. So again, these are becoming, they are a result of high sodium chloride. They are sending a signal to the afferent arteriole. These receptors, they will activate an increase in the intracellular calcium levels in the smooth muscle cells of the afferent arteriole. So when we have higher intracellular calcium in the smooth muscle cell of afferent arteriole, this will cause a vasoconstriction in the afferent arteriole. And we talked earlier about have an afferent arteriole. If there is a constriction in it, there is a decrease in the renal blood flow and the GFR. And this is a case where we have high sodium chloride. So the tubules are telling the kidney to filter less because we have higher filtration, we have high filtrate, we have high sodium chloride. So this is how it's signaled. The high intracellular calcium is going to cause a vasoconstriction, and it will deliver less blood to the glomeruli. And here we have the granular cells. So there is here like these channels in between the smooth muscle cells and the granular cells. And this increase in calcium will have its way and it's gonna leak some extra calcium into the granular cell. These granular cells, when they have extra calcium and when they have higher intracellular calcium, we will have decreased renal release. And this decreased renal release, again, is going to cause a decrease in the filtration and a decrease in the blood flow. So this is a sequence of events when we have higher sodium chloride. If we have lower, everything goes in the opposite. So lower sodium chloride here, we don't have as much ATP and adenosine binding to these receptors, and we don't have vasoconstriction or renin release. So we will have higher filtration rate because of the low sodium chloride in the tubules. Another effect from the tubules to the glomeruli is high protein intake and hyperglycemia. So when we have protein ingestion, what happens is we have higher amino acids. And these amino acids will bind into the proximal tubular, and we will be absorbed in the proximal tubular. And again, the macula densa is in the distal tubules. So if the amino acids are binding the sodium chloride and the sodium chloride is absorbed already in the proximal tubules, they will deliver less sodium chloride to the macula densa in the distal tubes, and the afferent arteriole resistance is going to be less, and we will increase the GFR. This is again the same effect of glucose, same as amino acid. They will bind sodium in the proximal tubules. Sodium, by the time you are in the distal tubules, is going to be less. So macula densa is going to sense less sodium chloride and we will send a signal to the kidney like, hey, we need more filtration because the macula densa has sensed a decrease in the sodium chloride. It says here amino acid, but again, glucose has the same exact sequence of events. It binds to the sodium in the proximal tubules, and it leads to decreased delivery of sodium chloride to the macula densa. And these are some questions for practice. I don't know if I should go over them, but this is the same graph I showed earlier. So lines A, B, and C on the figure show relative filtrability of glomerular capillaries of dextran molecules as a function of their molecular radiance and electrical charges. Which lines on the graph best describe the electrical charge of dextran? So different options. Again, we mentioned that the filtration barrier is negative. And for a negative filtration barrier, it's easier to filter what? A positive molecule. And it's less easy, but like, let's say medium, like difficulty for a neutral one, and it's most difficult for a negative one. So the answer in this case would be A, polycationic, positive, neutral, and polyanionic here. Which changes tend to increase the GFR? So these are different changes that can affect the GFR. First one is increased afferent arteriole resistance. So this will not actually increase the GFR because if we have an increased afferent arteriole resistance, we explained earlier how it's going to decrease the blood flow into the glomeruli. And of course, if the blood flow into the glomeruli is less, we have less glomerular filtration rate. Second option is decreased efferent arteriole resistance. So notice here it says decreased. If the efferent arteriole resistance is decreased, that means the blood leaving the glomeruli is going to have an easier time leaving the glomeruli. So we'll not have as much hydrostatic pressure in the glomeruli to have a good GFR. So this is not going to increase the GFR. C is increased glomerular capillary filtration coefficient. This is a direct one, filtration coefficient. If it's increased, it increases the GFR. So the answer here is C. D is, let's explain why it's not the D. It's increased Bowman capsule hydrostatic pressure. Again, this is going to push the fluid to not be filtered because Bowman's capsule is the other side. So it's going to push the fluid to not be filtered, and this will decrease the GFR. Decreased glomerular capillary hydrostatic pressure. This is a direct wrong answer. No, decreasing the hydrostatic pressure in the glomerular capillary will decrease the GFR. Next question, which changes would you expect to find after administering a vasodilator drug that causes 50% decrease arteriole resistance and no change on the arterial pressure? So if we have less afferent arteriole resistance, what we are expecting is the blood flow to the kidneys is going to be better, it's going to be easier. And if we have higher blood flow and higher blood flow into the glomeruli because of the afferent arteriole is decreasing its resistance, we will have also increased GFR. And as we mentioned about the peritubular capillaries, for any reason, if we have constriction, meaning increased resistance, they will have lower hydrostatic pressure. But in this case, we have a decrease in the afferent arteriole resistance, and this will cause an increase in the peritubular capillary hydrostatic pressure, which is C. Again, same point I discussed earlier about the peritubular capillary. They are a branch of the efferent arteriole, so they come after the afferent and the efferent. Whatever changes happen in the afferent or the efferent is going to affect the peritubular capillaries the same. It's not like the GFR and the renal blood flow, which have like different effects by the afferent and efferent arteriole resistances. Next question is giving the following measurement, calculate the filtration fraction. And you have 4 values here. One is the glomerular capillary hydrostatic pressure. We have the Bowman's capsule hydrostatic pressure, colloid osmotic pressure in the glomerular capillary, and the filtration coefficient. And last one is renal plasma flow. So the filtration fraction, we know it's the GFR, the glomerular filtration rate, over the renal plasma flow. So in this question, we don't have the GFR, but they gave us all of the variables we need to calculate the GFR, and we can easily calculate it. So it's the hydrostatic pressure minus the Bowman space hydrostatic pressure minus the oncotic pressure of the glomerular capillaries. So 70 minus 20 minus 35 is going to give us the net filtration pressure. Let me check how much that is. 70 minus 35 minus 20 is going to give us, yes, a filtration net pressure of 15. And the glomerular capillary filtration coefficient is 10. So 15 multiplied by 10 is the GFR, which is 150. GFR is 150. Renal plasma flow is 428. Now we have one last simple step. 150 over 428 is going to give us 0.35. Yes. Let me check. Yes, it's 0.35. These are the resources. And lastly, please share your feedback about the past sessions of renal cycle during this blog and this QR code. Thank you.